and I will share it to you all, and there is no issue with it. Okay, now we have to go for the sensory examination. Sensory examination is very important in the stroke patients because there are some sensation loss in the patient of a stroke. First of all, there are three types of sensations. First is the superficial, second is deep, and third is combined cortic. Voice is breaking. Is my voice is breaking to everyone?
No, sir.
Dear, please check your
No,
internet
sir, it's
connection.
not breaking.
Okay. So let's continue. In the sensory examination, we have superficial, deep, and combined cortical sensations. Okay. Now, superficial sensation includes the pain, touch, and temperature. The touch includes both fine touch and crude touch. We have to go for the both fine touch and crude touch assessment. For pain, we have to assess for the pain, touch, and temperature. For temperature, we can we will stick any hot or cold substance to the patient's skin, and we will ask the patient to tell the temperature, is the patient is able to feel the temperature or not. Then we have to go for the deep sensory examination. For deep sensory examination, we have pressure, vibration, and joint position sense. Okay. Joint position sense. How to check joint position sense? For example, if I have a patient, I will ask the patient to close his or her eyes. Then I will flex passively the elbow joint of the right elbow joint of the patient, and then I will ask the patient to take his other hand in the same position without looking at the hand. Okay, so this is called the joint position sense. Mostly the patient have joint position sense correct, but in some cases it can be diminished. Now, third one is combined cortical sensation. Combined cortical sensation, it includes tactile localization. What is tactile localization? So we will ask the patient to close his or her eyes, and then we will touch the skin of the person, and then we will ask the person to locate that touch. Okay, if the patient is able to locate that touch, then the tactile localization sensation is very normal. But if the patient does not able to localize the touch of the on the skin, then it is abnormal sensation. Okay, then now stereognosis. What is stereognosis? So it is just stereognosis is just we will ask the patient to close his or her eyes, and then we will give any familiar substance, any familiar object to the patient, and the patient will feel that object with his or her hand, with his or her fingers, and then he will try to tell us that what substance we have given to him. Okay, if the patient is able to identify that object with his or her eyes closed, then the stereognosis is very normal. If not, then it is not normal. Same, 2 point discrimination and double simultaneous stimulation is also very important to check in the patient of the stroke. Now, motor examination. As we all know that stroke in as we all know that in stroke, motor function is very decreased. Motor function is mostly affected. So we have to check for the motor function very well. First of all, in the patients of a stroke, there is hypotonicity present immediately after the stroke. Just after the stroke attack, the hypotonicity is present in the patient's body, but this hypotonicity is not permanent. In 90% of the cases, this hypotonicity will convert into hypertonicity, and this conversion of hypotonicity into hypertonicity is called the obligatory synergy. Okay, I am repeating it once again, that immediately after stroke, hypotonicity is present in the patient, but this hypotonicity is very short lived, and in the 90% of the cases, this hypotonicity emerges into the hypertonicity, and this conversion is simply called the obligatory synergy. Okay, now apart from this synergy, spasticity is also present in the patients of stroke. So in upper extremity, spasticity is very strong in this compartment, in these muscles. First is the scapular retractors, shoulder adductor and internal rotators, elbow flexor, forearm pronators, and wrist and finger flexors. Okay, now for the lower limb, for the lower extremity, the spasticity is very strong in the pelvic retractors, hip adductors, hip internal rotators, hip extensor, knee extensor, plantar flexor, and toe flexor. These all muscles are very spastic in nature in the patients of a stroke. Now there is a scale called modified Ashworth scale. I don't know you all know this or not. I think you all know this, but still, modified Ashworth scale MAS, it is very important to check for the tone of the patient, to check for the motor examination, to check for the muscle tone of the person. Okay, so it includes six grades starting from grade 0, then grade 1, grade 1 plus, grade 2, 3 and 4. In grade 0 there is no increase in muscle tone. It means that the muscle tone of the patient is very normal. There is no increase in the muscle tone. Okay, now grade 1. Grade 1 is that there is slight increase in the muscle tone and minimal resistance at the end ROM. There is slight increase in the tone of the muscle, and the resistance is felt very minimally at the end ROM, at the end range of motion. Grade 1 and grade 1 plus again is very similar to each other. The only difference between grade 1 and grade 1 plus is in grade 1 the resistance has been felt at the end of the range of motion, but in grade 1 plus the resistance will be felt throughout the throughout the range of motion. Here again the slight increase in muscle tone and minimal resistance throughout the range of motion. In grade 1 it was at just the end of the range of motion, but in grade 1 plus the resistance is throughout the range of motion. Okay, now in grade 2, the muscle tone will increase further throughout the range of motion, but the affected part will move. It will be difficult to move, but it will move and the tone will increase more. In the grade 3, there is considerable amount in the muscle tone. The muscle tone will go more higher and the passive movement is very difficult passive movement in the patient's body. Okay, now then at last grade 4. In the grade 4 the muscle tone will be very high and the affected part will be very rigid in movement. It will very difficult to move the affected part in passive movement too. Okay, now, after this modified Ashworth scale, we have to check for the voluntary movement of the patient. Voluntary movement is completely affected in the patient of a stroke. Okay, so and in voluntary movement, if we ask the patient to do some voluntary movement, then we have two different synergy patterns are visible during the movement of the patient's body. Okay, so what are the synergy patterns? What are the synergy patterns? These synergy patterns are basically the characteristic feature of the patients of a stroke. This in a stroke patients these synergy patterns are present. So synergy patterns are basically the abnormal movement of the group of joints together. Basically, if you perform any movement, for example, if you are doing the wrist flexion, then the wrist flexors are working to flex the wrist. But apart from the wrist flexors, the other muscles are working as the stabilizers that stabilizes the other joints nearby the wrist, such as the stabilizers are stabilizing our elbow joint and shoulder joint. Okay, but in the stroke patients the stabilizers doesn't work properly and it also starts to move. So if we ask the patient to move one joint, it will move all the related joints, it will move all the surrounding joints, and this is called the synergy patterns. It means that there is the abnormal movement of the group of joints together. Okay, so mainly two synergy patterns are seen in the stroke patient. First is the flexion synergy patterns and second is the extension synergy patterns. Now, what are the flexion and extension synergy patterns in the upper limb and in the lower limb? We will discuss in the next slide. But still, there are some muscles that are not involved in the synergy. Okay, majority of the muscles are involved in the synergy patterns of both upper extremity and lower extremity. But there are some muscles that are not involved in the synergy patterns, such as latissimus dorsi, teres major, serratus anterior, finger extensors and ankle everters. And these five muscles are very difficult to recover because they are not involved in the synergy patterns. Okay, now synergy patterns, flexion synergy patterns for upper limb. In upper limb we have scapular retraction, shoulder abduction and external rotation, elbow flexion, forearm supination, wrist and finger flexion. It means if we ask the patient to flex any part of the upper extremity, these all movements will occur together. These all are the abnormal synergy patterns because of the loss of the function of the stabilizer muscles in the human body, in the arm or in the upper extremity. Okay, now same in the lower extremity, the flexion synergy pattern is hip flexion, abduction and external rotation, knee flexion, ankle dorsiflexion and inversion. Okay. Hmm. For extension synergy pattern in the upper extremity, we have scapular retraction, shoulder adduction and internal rotation, elbow extension, forearm pronation, and wrist and finger extension. Just opposite of the flexion synergy pattern of the upper extremity. And for the lower extremity, we have hip extension, adduction and internal rotation, knee extension, ankle plantar flexion and eversion. Okay, so these all are the synergy patterns that occur in the upper extremity and the lower extremity. Okay, now after this we have to go for the MMT examination. Manual muscle testing is very important is very important in the patients of a stroke. Why? Because in the treatment protocol we have to make the we have to add the strength training program, we have to add the strength gain program, and to proper and to make the proper strength gaining program, we have to check for the MMT, we have to check for the manual muscle testing, we have to check for the muscle power. Then on the basis of the muscle power of the patient, we will design the strength gaining program and other treatment protocol, whether it works anti-gravity, whether it works only after eliminating of the gravity, or whether it works after giving any manual resistance too. So MMT is very important to assess in the patients of a stroke. Then coordination is also very important to assess about. Then the next one is balance. We will check the balance, we will assess the balance in the patient's body by using the Burge balance test. I hope you all know Burge balance test. It is 11 it contains 11 different activities, like sitting to standing, standing to sitting, supine to prone. Okay, so it involves 11 to 15 different activities, and we will perform all the activities by the patient, and then we will give the scaling on the basis of the activity done by the patient. So balance testing is done by Burge balance test. Okay, now gait analysis, again I had already discussed about the gait analysis, that we have to go for the we have to check for the each and every parameters of the gait, including the step length, the stride length, the cadence, the step duration, stride duration, and what are the movements of the limb, such as the is the patient performing all the functions, all the events of the gait cycle, such as the heel off, the toe off, the foot flat, the mid stance, the heel strike. Okay, and in the swing phase, the acceleration, the mid swing, and the deceleration. Is the patient able to do all these events, or the patient is not able to do all these events? Okay, so we have to go for each and every analysis, we have to go for each and every parameter for the gate. Okay, so this was the assessment protocol. Now for the physiotherapy management, let's start for the physiotherapy management. After all these assessment, we have now to proceed for the physiotherapy management. Keep one thing in mind, that the assessment is very important in any patient, whether it is of the whether it is of the neuro, it is of the cardio, ortho, or any department. Assessment is very important. If your assessment will be correct, if your assessment will be right, then the patient will be able to recover soon. Then you will be able to make the proper and the perfect treatment protocol for the patient. But if the assessment is not correct, if the assessment is not good, then you can't recover patient so smoothly. Okay, so now let's move on to the physiotherapy management. Then what are the first of all, we have to set the goals and aims in any treatment protocol. What are your goals? What goals you want to see in the patient's body? What goals and aims you want to see in the patient's condition? So here in the stroke patients, we have the primary goal is to regain motor function and sensory function. After that we have to improve the gait of the patient, then improve muscle strength and performance, then improve the ADL, activities of daily living, then we have to prevent the other complications. Now see, in stroke patients, there are a variety of complications ranging from the orthopedic to the psychological condition. Many deformities are seen in the patients of a stroke. The shoulder joint gets dislocated in the patients of a stroke due to the hard muscle pull. As we all know that the shoulder joint is one of the very unstable joint of the human body, and due to the hard muscle pull, due to the excess muscle pull in the stroke patients, the shoulder joint gets sometimes subluxed, or it also gets dislocated. So many different complications are seen. Many patients gets bedridden for a longer time, and it will lead to the bed sore, or the pressure sore. So to prevent other complications, we have to make the treatment protocol, and at last to improve the postural control and the balance. Okay, postural control and the balance is also very important aim and goal to achieve in the patient of stroke. Now, for these all goals, what we have to do, we will discuss just one slide. Now, variation of recovery. What are the factors that depends? What are the factors that influence the recovery of the patient? So there are mainly four factors that define the recovery of the patient. First of all, the severity of the stroke. How severe the stroke was. It is very important to discuss about that what is the severity of the stroke, how serious, how severe the stroke was, how much area of the brain is affected. If there is the ischemia, if there is the ischemic attack, then we have to check for the how many we have to check for the how much area of the brain is affected due to the ischemia or due to the hemorrhage. So severity of the stroke is very important to check for. Okay, after the severity we have to also check for the type of stroke, whether it is of the ischemic type or hemorrhagic type. Okay, then the risk factor or the history, as we have discussed as we have discussed earlier in this lecture, that risk factor and history is very important to assess about in the patients of the stroke. And at last, the age of the patient, it also very matters in the patients of a stroke. Now, for the management, we have different techniques, we have a variety of techniques available to manage and to treat the stroke through physiotherapy, but always integrated and combined treatment protocol is always beneficial in any condition. It is not only the condition of a stroke, in any condition, whether it is Parkinson, whether it is the case of Parkinson, whether it is the case of a stroke or CP or any condition, the integrated and combined treatment protocol is always beneficial. You cannot recover any patient with single treatment protocol with only one type of treatment. Okay, that's why the integrated and combined treatment protocol is always beneficial. The integrated approach here in the stroke, it will include the positioning of the patient, the chest physiotherapy of the patient, the balance training, strength training, and the gait training. These all are very important to rehab the patients of stroke. Now, for positioning, why positioning is very important? Because it is responsible to maintain the skeletal alignment. We have discussed earlier that the postural abnormality is commonly seen in the patients of a stroke. So to manage that postural abnormality, positioning is very important because it aligns the skeletal system in a perfect manner. Then it also prevents skeletal deformity, as we have discussed earlier. Now, it also gives them a stable base of support. Base of support is very important in the patients of a stroke. We have to provide a stable and a large base of support. Why? Because the patient is not able to balance the body. So, to give the balance to the patient, a stable and a large base of support is very important, because when the base of support will be large, the center of gravity will fall down, and the patient will not be able to and the patient will able to keep their body stable. That's why a large base of support is very important in the initial stage of the stroke patient. Now, positioning also controls the abnormal movement patterns. Okay, it also manages the pressure, because if the patient will be bedridden for the longer time, then it will lead to the pressure source or the bed source. So to manage the pressure source and the bed source, positioning is very important. It will also decrease the fatigue, it will also decrease the muscle fatigue, it will also improve the respiratory and circulatory function. Okay, respiratory and circulatory function is very important. And the stroke patients it is and in the stroke patients, there are chance that respiratory and circulatory function will be diminished. So positioning will also improve the respiratory and circulatory function. And pressure source, it will prevent pressure source, as we have discussed earlier. Now, the positioning should be done in supine, the side lying on affected side, side lying on non-affected side, prone, and sitting. Okay, so in these all the positioning should be done. There are some diagrams of the positioning that I will share with you all in the group after this presentation, after this meeting. Okay, you can check it out, the positioning protocol, how we place pillow in the patient, how we place pillow at different joints of the patient. These all diagrams I will share with you all in the group after this meeting. Okay, now breathing exercises are again very important. Why? Because the patient is bedridden for a longer time, and there are chances that the patient will not be able to breathe easily. So breathing exercise is important. chest expansion exercises are again important. Postural drainage is very important. And early mobilization, many people think that early mobilization is not beneficial for the patients of a stroke, but early mobilization is very beneficial in the stroke patients. We have to mobilize the patients in the acute stage, in the early stage. Early mobilization includes active turning, supine to sitting, then sitting to supine, sideline to supine, sideline to prone, etc. Okay, then we have to facilitate the movement of functional limb, the limb that is functional, the limb that is non affected. We have to facilitate the movement of that functional limb. Correct. Now, for the joint flexibility and stability, what are the measures that we have to perform for the joint flexibility and stability? Okay, so for joint flexibility and stability, first of all, we have to go for the soft tissue manipulation. The ROM exercises, it means the active and the passive movement exercises, we have to perform that. And with active range of motion, with active exercises, we have to give the terminal stretch. What is this means that we have to get the patient into the end range of motion, and after achieving the end range of motion, we have to give a mild stretch at the end range of motion. Okay, so active range of motion with the terminal stretch. Now splinting, it is also very important. Now edema and tonal changes can be present during the stroke recovery process, and it can create problem during the wrist extension. Okay, so in this case, if the edema and tonal changes are present, the carpal bone should be mobilized to prevent this all. Now, as we all know, spasticity is present in the patients of a stroke. So for spasticity, we have a stretching program. We have to go for the program. Then active contraction of the dorsiflexors, flexors, and positioning. We have already discussed this positioning. Now, when sitting in wheelchair, if the patient is present, if the patient has been sitting on the wheelchair, the upper extremity positioning has been should be done, like the shoulder should be 5-degree abduction. Sorry, this is ABD. 5-degree abduction and flexion, slight flexion. The elbow should be 90-degree flexed. Forearm should be pronated, and hand should be in the functional resting position. If the patient is present on the wheelchair, then this position of the upper extremity should be achieved either actively or passively. Okay, now we have now for strength. Now the next one is the strength. To gain the strength, what we have to do, as we have discussed earlier in the assessment protocol, in the assessment lecture, that the MMT is very important to assess about in the patients of a stroke. Why MMT is very important? I have told you that to gain this that to include the strength training program, MMT is very important. Now if the patient have the MMT less than 3, it means the patient is not able to perform movement against the gravity. Then we have to give gravity eliminating exercises with power boards, with sling, with suspension, and aquatic exercises or hydrotherapy. Only if the patient's MMT is less than 3, it means the patient is not able to move their muscles. It means the muscles are not working even against the gravity. So we have to add the gravity eliminating exercises for the patients with MMT is equal to 3. If the MMT of the patient is 3, then gravity resisted exercises like arm lift, leg lift can be performed. The patient is now able to work, the patient's muscles are able to work against the gravity. So we will add the movement like arm lift, leg lift, quadriceps curl, etc. Now for the patients with movement sorry now for the patient with the MMT more than 3, if the patient's MMT is more than 3, then it is too good, and exercise with manual external resistance can be done. In the patients with MMT is equal to 3, we will only give the gravity, if the only resistance is the gravity. But in the patients with MMT more than 3, apart from the gravity, we can also give some external manual resistance like free weights, like therabands, like sandbags. We can exercise the patient with sandbags. It will give the manual external resistance to the muscle. It will also help to strength, it will also help to gain the strength of the patient. Okay, now for the strength, again we have to do resistance training should be done 2 to 3 times a week. In a week, 2 to 3 times a resistance training should be done, and 3 sets of 8 to 12 session it's repetition. 3 sets of 8 to 12 repetition per session should be performed by the patient. Now resistance training with task oriented activity is very important. Task oriented exercises are very important, are very beneficial in the patients of a stroke, and again in the patients of Parkinson and CP2. So task oriented activity is very important. Apart from this, all some weight bearing exercises like sit to a stand, wall squats, step ups, stair climbing with weight cups. We will tie the weight cups, we will tie the sandbags into the patient's leg, and then we will ask the patient to climb the stair. We will support the patient, and then we will ask the patient to uh, climb the stair. Then kneeling and half kneeling, this position is also very important to gain the strength. Kneeling and half kneeling is also responsible to balance the body. It also helps to regain the balance of the body. But here, but still, here in the strength training program, we can also add kneeling and half kneeling positions. Okay, now to manage the spasticity and movement control, what are the treatment protocols? What can we do to manage the spasticity and the movement control? So, when spasticity is present, stretching is very important. We have to go for the stretching. We have to go for the PNF stretching too. The hold, relax, the contract, relax stretching. It is very important in the patients of a stroke. Then rhythmic rotation. Rhythmic rotation of the trunk, the upper trunk, the lower trunk is very important. The axial trunk rotation in the side lying sitting and hook line position, we have to ask the patient to be in the side lying position, and then we have to ask the patient to rotate the axial trunk. If the patient is not able to do it actively, then we will do it passively, but the patient's participation is very important here too. Now, weight bearing exercises are very important. Weight bearing exercises like sit to stand, etc. Now, rocking movement, PNF patterns and PNF stretching. PNF patterns are one of the very important treatment protocol in the patients of a stroke. PNF is the proprioceptive neuromuscular facilitation. I think you all know this PNF patterns. So the upper extremity and lower extremity diagonal patterns, that is D1 flexion, D2 flexion, D1 extension, and D2 extension. These all are very important. Apart from the upper extremity and the lower extremity patterns, the trunk patterns is also very important to manage the stroke patients. So PNF stretching and PNF patterns are very important in the patients of stroke. Then again, task oriented exercises. Task oriented exercises are also very important. Like we will ask the patient to lift object from one place and to take the object on the second on the other place, like that. Okay, then breathing and half breathing. This breathing and half breathing are the weight bearing exercises. Okay, so breathing and half breathing. Apart from this breathing, half breathing, the sit to a stand, single leg stand, toe walking, these all are very important for the movement control and to manage the spasticity. Then postural control, balance, and functional mobility. As we all know, in the patients of a stroke, there is a loss of postural control. The patient cannot control his or her posture by itself. The balance is also gets impaired. The functional mobility is also very diminished. So to manage this all, we have to do some exercises like rolling, sit to a stand, weight shifting. Weight shifting is very important in the postural control and especially in the balance training. Weight shifting is very important. Weight shifting, forward bending, side kicking with one leg, backward walking, reaching activity. Now this reaching activity is very important, it can be done in different positions. Okay, so this reaching activity is very important and this can be done in many positions. Like we will perform the reaching activity in sitting position, in kneeling position, in half kneeling position, in quadruped position. Okay, so reaching activity is very important and it will help to regain the balance of the patient. It will help to regain the postural control of the patient, the functional mobility of the patient, the coordination of the patient. Okay, so reaching activity are very important and we can perform the reaching activity in different functions, in different positions. Okay, now throwing activities. We will ask the patient to throw some ball. We will give the ball to the patient and we will ask to throw at the particular place. Okay, so throwing activities are also very important in the condition of a stroke to manage the postural control. Especially the throwing activities helps to regain the balance and the balance, the functional mobility and the coordination. Apart from this all, we can do some coordination exercises like finger to finger, finger to nose. We will point some objects, we will point some uh, objects on the table and then we will ask the patient to put that object from one point and we to put that object on the second point. Okay, so this all can be done to regain the postural control, the balance, and the functional mobility. Now, to improve the upper extremity and the lower extremity function, what we will have to do? Again, early mobilization is very important. Okay, early mobilization is very important, and a positioning is also very important. See, this positioning is not only responsible for to prevent the pressure sores, or to increase the blood circulation and the respiratory condition of the patient. This positioning plays a very important role. I think you all know one technique, that is the Bobath or NDT technique, neurodevelopment technique. This Bobath and NDT technique also defines the positioning. It includes the majority of the majority of the exercises of the Bobath or NDT includes positioning, because positioning is the master stroke in the patient of a stroke. With the help of positioning, we can achieve many different functions. We can achieve many different aims and goals. So early mobilization and positioning is again very important. Now, upper limb and lower limb weight bearing exercises, dynamic stabilization exercises, lifting activities. We will ask the patient to lift some objects, like in PRE, in the progressive resistor exercises. We ask the patient to lift some object, to lift some weight, and gradually we increase the weight according to the patient's muscle and according to the patient's condition. So like that, lifting activities is also very important. Now, kitchen sink exercises. This kitchen sink exercises is very important for improvement of the upper extremity and lower extremity function, along with balance training. Kitchen sink exercises are very important in balance training too. Kitchen sink exercises includes 3 to 4 different activities like heel raises, toe standing, toe walking, partial wall squats, chair raises, single limb stance with side kick and back kick. Okay, so these all activities are in the kitchen sink exercises. Again, I am repeating this. If you want, you can mention it in your notes. That in kitchen sink exercises, we have heel raises, we have toe standing, we have toe walking, we have partial wall squats, we have chair rises, we have single limb stance with side kick and back kick both. This kitchen sink exercise is this is also performed in the patient of Parkinson or in the patient of ataxia. As we all know, in the ataxia there is the loss of balance and coordination mainly. So in ataxia, these kitchen sink exercises are very important to achieve and to regain the balance and the coordination of the patient. Apart from this kitchen sink exercise, the functional movement like hand to mouth, hand to opposite shoulder, we will ask the patient to move their hand to the mouth, or to move their hand and touch the opposite shoulder. So these functional movements are very important, and it will regain the movement and it will improve the function of upper extremity along with some balance training. Now, sidestepping, cycling and treadmill training is also very important, because cycling and treadmill training these exercises works on a group of muscle together. So with the help of cycling and treadmill training, we can achieve some more functions of the upper extremity and the lower extremity. Okay, now at last, gait training. Last exercise is the gait training, and gait training is very important. Apart from gait training, we have to go for the stair climbing. Now, for the gait training, what we will do, we will ask the patient to stand, to be we will hold the patient in the different positions. We will hold the patient in the different events of the gait cycle. Like in the stance phase, what we have, first of all, we have heel strike. So we will hold the patient for 10 to 15 seconds in the heel strike. Then we will go for the foot flat. Then we will go for the mid stance, then heel off, and then toe off. And similarly, in the swing phase, we have acceleration, we have mid swing, and we have deceleration. So we will hold the patient in all these positions for 15 to 20 seconds or 10 to 15 seconds, according to your patient's severity and according to your patient's condition. Okay, now after this gait training, pulmonary rehab is also one more thing. In locomotor or gait training, we have to give verbal commands to the patient. We have to give visual and auditory cues to the patient, because this all provides sensory feedback to the patient's brain, and it will also help to regain the gait activity, to regain the gait cycle of the patient. Okay, then task specific training will again be more beneficial in the case of stroke patients. Here in the gait training too, okay, in the gait training, task specific training will also be very beneficial. Apart from this all, Frankel exercise can also be done in the patients of a stroke. Now for pulmonary rehab, we have there are mainly of three pulmonary complications that are seen in the patients of in the patients of a stroke, like upper airway obstruction, the restrictive disorder, and the aspiration pneumonia, because the patient is not able to move his or her the facial muscles are also gets paralyzed. So aspiration pneumonia can also be seen in the patient of a stroke. And to prevent this all, we have to go for the diaphragmatic breathing, we have to go for the ear shifting techniques, we have to go for the vibration, shaking, coughing and huffing techniques for the patient. We have to go for the percussion and other postural drainage techniques. Now apart from this all, we have to make the home treatment plan. We have to go for the HEP, home treatment plan for the patient. Okay, now first of all, make sure the patient understands about the importance of self exercises. Again, you have to elaborate the patient about the benefits of the self exercises and the active participation in the treatment. Apart from this all, early morning warm-ups, stretching and strengthening in supine, sitting, standing, etc. is also very important. You have to teach the patients for the self stretching of different muscles. Okay, so this was all about the management and the assessment of the stroke patients. I will share this slide in the group. You can simply check it out. If you have any doubt in this all, you can simply WhatsApp me in the group or in the personal DM. And okay, so that's all.